Very good evening to one and all present here. I am Dr. Praveen Khwairakpam, bringing to you a rather interesting case of a male patient with a sinonasal mass. The patient was a 26 years old male hailing from Kolhapur, presented with the chief complaints of diminution of vision in the left eye since 8 days. Patient also had complaints of bilateral nasal obstruction, more on the right than on the left, since 2 months, with headaches localized in the frontal aspect since 2 months. There is history of complete loss of vision in the right eye since last 3 years, with history of sided rhinoorbital mass biopsy with FES, with medial orbital wall decompression surgery 3 years back in the year 2021. Patient has no known comorbidities. However, there is no history of fever, weight loss, decreased or altered sensation of smell, nasal bleed, trauma, or breathlessness. On clinical examination, the patient is vitally stable, conscious, cooperative, and well-oriented to time, place, and person. On anterior rhinoscopy, there was not much significant finding. However, a minimal crusting was noted in the left nasal cavity, and a mild PNS tenderness could be elicited in the frontal aspect. The ocular examination suggested that there was complete loss of vision in the right eye, with left eye vision being only 6/24. Extraocular movements of the right eye was significantly reduced on the medial aspect, and the extraocular movements were intact in the left eye. Ear and oral cavity examinations were well within the normal limits. We did diagnostic nasal endoscopy preoperatively, and we could see that in the right nasal cavity there was a mass which was more on the lateral aspect of the nasal cavity, which was bleeding on touch, and it was significantly adherent to the lateral wall of the nose. On the left nasal cavity, there was not much significant finding except for a pale polypoidal mucosa in the left sphenoethmoidal recess. Imaging study was suggested, and we did MRI brain with PNS orbit contrast, and in that we could see a hyper-intense density of a soft tissue mass which was in the right maxillary sinus, and it was extending into the right pterygopalatine fossa, and it was further extending beyond that into the orbital apex, and it was extending into the cavernous sinus as well. The mass was encasing both the optic nerves, and it was forming a pachymeningeal thickening, which was kind of looking like a fungal meningitis picture. After due anesthesia and medicine fitness, we took the patient for surgery, and in the surgery we lateralized the inferior turbinate in the right nasal cavity, started debulking the mass after releasing the adherent part, and then took the sample for histopathology examination, and then we reached till the orbital apex and removed the mass in toto, leaving the intracranial mass behind. So immediate post-operative landmarks you can see here. Wide maxillary os you can see, and we have done the partial medial turbinectomy, and then you can see the open frontal sinus and the sphenoid sinus, and we have reached till the orbital apex as well. Histopathology report was suggestive of IgG4 related disease. IgG4 related disease is suggested on the findings of plasma lymphocytic infiltration that was seen in the tissue, and then we could see perivascular fibrosis with infiltration of the endothelial cells, and also the styrofoam fibrosis that was present, and this further suggested for IgG4 serum levels, which was significantly raised. That was 3.37 grams per liter, and his immunohistochemistry was sent for. In that, it was confirmed that patient had IgG4 related disease. IgG4 related disease is basically a pseudotumor. So post-operatively, we managed the patient with Merisol nasal pack in situ for 2 days. And then patient was on IV antibiotics, analgesics, antihistaminics, nasal douching, and other supportive medications with a total hospital stay of 6 days. And patient was discharged on oral medications and advised for nasal douching. Patient was started on tablet prednisolone 60 mg per oral OD in tapering doses. Post-operative DNA was done for the patient at 1 month and 5 months. In the video, you can see that at 1 month, there was no evidence of any disease in the right nasal cavity. Similarly, at 5 months follow-up, you can see that there was no evidence of disease or recurrence except for some polypoidal mass. Imaging was advised again for 1 month follow-up and 5 months follow-up. In that, there was only slight mucosal edema, which we can notice at 1 month follow-up, which was significantly reduced at 5 months time, and there was no recurrence of the disease. Patient was still on tablet prednisolone at a tapering dose. Tablet prednisolone was continued for 3 months. Nasal douching was still advised, and after 15 days, the prednisolone was tapered down to 40 mg OD, and patient started to develop Cushingoid features with rashes over face and hands due to the drug reaction, and patient was shifted to prednisolone 20 mg OD, and dermatology consultation was sought and advices were followed through accordingly. Patient is currently on tablet prednisolone 5 mg OD every alternate day with fluticasone nasal spray. This is the post-op picture of the patient. At 1 month, you can see the flare-up because of the steroid, and at 5 months, that flare-up is significantly reduced. IgG4 related disease is sort of a pseudotumor which is characterized by multi-organ fibroinflammatory condition, most commonly in the pancreas, kidneys, salivary glands, but sinonasal manifestation is very rare, accounting up to 3 to 15% of the cases. And the treatment of choice is glucocorticoids. Newer treatments suggest for immunotherapy, which is inebilizumab or rituximab therapy. Thank you.
I would request Dr. Anant Rajmane sir to hand over the certificate to Dr. Praveen. Next is Dr. Ashish.